speaker is a very important speaker for me because he's a good colleague of mine. We work together. And he is Professor Vinod Patel. And he is well known in the diabetes circle in nationally and internationally. He has done so many, he has published so many publications. If you just Google Vinod Patel, you can see so many videos of him teaching medical students. He is very much involved in teaching. He is currently Professor of Clinical Sciences in Warwick University. And he's an honorary consultant physician with us in George Eliot Hospital. Whenever Vinod comes to do a ward round, I can see 5, 6, 7, 10 medical students coming before that. So when I see those medical students, then I guess that Vinod is coming to do a ward round with us. So without any delay, I will ask Vinod to come and share his alphabetic strategy for diabetes with us.
Thank you very much, Kazi. What he hasn't told you is that he's actually my boss, actually. And it's great working for him. He really has done extremely well in setting up our 42-bedded acute medical unit with the help of people like Teresa Dowsing as well. So I've only got about 12 minutes, I understand that. So I'll do all of diabetes care in 12 minutes. It won't take me long because we only have to deal with 7 letters of the alphabet. I'm sure you'll all appreciate that diabetes is an incredibly important problem. In this country, we have 3.8 million people with diabetes. But what is absolutely stark is that 90% of the cases of diabetes are actually preventable. And we're spending something like £10 billion of money on it. But the problem is worldwide. On planet Earth, we have 415 million people diagnosed with diabetes. And remember that 90% of this can be actually be prevented. And we're here to celebrate the medical school output from Pakistan particularly, but you can see that in Pakistan that the rate of diabetes is around 10%, and in India it's 10%. So it's a very, very large number of people. I won't talk about Europe. And although I'm going to go through the evidence base, at the center of everything that we do is going to be a patient. And we always have patients like this, people who are on various tablets, their cholesterol's a little bit high, their blood pressure's a little bit high, their diabetes controls is a little bit high, and they're heading for kidney failure, and they've already had significant eye disease. So what I'm going to give you is an idea of how we can go about reducing all these complications of diabetes. And irrespective of whether you work in public health, as a urologist, neurosurgeon, physician, frailty, there are basic things that we can do for our patients with diabetes to make their life a bit better. So it's the commonest cause of blindness under the age of 65 in this country, commonest cause of end-stage renal failure, foot problems, and eye disease as well. But we can get all these benefits. I won't have time to go through the evidence base today for accruing these benefits, but I can assure you that we can have all those benefits if we do the basics of diabetes care well. And this, I could actually finish talking to you on this and just take some questions, because this is our diabetes care checklist. A for advice on lifestyle, B for blood pressure, C for cholesterol, D for diabetes control, E for eyes, F for feet, and G for guardian drugs. We've presented this work in about 30 different countries now around the world, and the International Diabetes Federation also see this as a good way forward. And because this is a public domain strategy, if anyone wants to use it or share our materials, then it's entirely up to them. So let me quickly go through the evidence base. So when it comes to lifestyle, the most important aspect of lifestyle for prevention of diabetes is obesity. Now, even when I talk to the National Director for Diabetes or Obesity, they do not know this statistic. When I ask them a simple question, is that if you compare somebody with a body mass index, as you can see here, less than 23 versus somebody with 35, which is not that overweight, and I say to them, what is the increased risk of diabetes? They'll say 100%. It's not. It's 4,200%, because it's times 42, and it's 9,300%. And this is Wonga interest rates, if you know what I mean. Okay? So then we also have to think carefully about physical activity. And the problem with our South Asian community is that we simply do not exercise enough. We do not do enough brisk walking, and we don't do enough muscle strengthening exercises. And the problem with diet, and today the food was delicious, but it was far too much carbohydrate. So we must cut down carbohydrate if we want to reduce our risk of diabetes. More fresh fruits and vegetables and more carbohydrates. So that's the aspects of advice. Blood pressure is simple. We know what to do for blood pressure. We know effective agents like ACE inhibitors, sartans, and diuretics. Why? Because even if the blood pressure is slightly lower, as you can see here, 144/82 versus 154/87, you get all those beneficial effects. Less strokes, less heart failure, but deaths are reduced by 32%. And you must agree that that's a good outcome. Now, we're not going to go through cholesterol in a great deal of detail, but sufficient to say that cholesterol is very, very important, as you're well aware. So if I move on, what we need to do for cholesterol, just one point I want to make, is that if you've already had a heart attack or a stroke, the correct dose of atorvastatin is 80 to start with, not to titrate up, but to start with, and we're often getting that wrong. And we also need to make sure that our primary prevention patients are on atorvastatin 20 milligrams daily. So D now is diabetes control, so we're almost halfway through the strategy. And the main point I'd like to make is that for those of you in general practice or in diabetes, we all despair because half of our patients are poorly controlled. But the good news is that any reduction in hemoglobin A1c will give you these beneficial effects. So 1% reduction in hemoglobin A1c, which is 10 millimoles per mole, will reduce amputation rates by 43%, kidney disease, deaths as well, heart attacks and strokes. Okay, and one very critical point of when you choose an agent for diabetes care, you have to try and choose something that actually doesn't cause hypoglycemia, because in the long term, that can give you permanent cognitive dysfunction, even dementia, and the older style sulfonylureas like glibenclamide are associated with cardiac arrhythmias. So we have generic, cheap drugs like gliclazide that are far less far safer, I should say. Now, I think this is one slide that I would really like you to think about. I think we all know that statins reduce deaths. We all have this perception that they reduce deaths, and it's true. If you treat 30 patients at high cardiovascular risk for 5.4 years, that's 162 treatment years, you save one life. Can you name any other drugs that save lives in diabetes care?
But it causes diabetes as well.
For every 5 cardiovascular events you prevent, you get 1 new case of diabetes. I quite agree.
Yeah.
All right, but the balance is definitely in favor, because what do you want to do? Be dead or have diabetes? So, in that way, the balance is towards the statin. The other big class of drugs that we like using is ACE inhibitors. But here you have to treat 56 patients for 5 years, which is 280 treatment years to save 1 life. What drug is better than either of these two for diabetes care? It's the new class of drugs that we have for diabetes. And these are called the sodium glucose co-transporter 2 reuptake inhibitors. So you actually pee out sugar. So remember all those time that we spent trying to stop our patients having glycosuria. These drugs cause glycosuria. But look at the benefit. You only need to treat 39 patients for 3 years to get that benefit, to save 1 death. So they're more effective than ACE inhibitors or statins. Eye disease is our patients must be screened regularly, so this back of the eye that looks like a pizza doesn't become even worse and the patient loses vision. So that's about screening the eyes and treating with laser treatment when needed. Foot care is all about making sure that we have a good strategy to reduce foot complications, and we have lots and lots of local care guidelines that could work very well. G is for guardian drugs. So when it comes to guardian drugs, this is going to be all about the appropriate use of aspirin, the appropriate use of ACE inhibitors in people who have kidney disease, and in some ways you could argue that statins are a guardian drug as well because we use them for primary prevention. We all worry about kidney failure in our relatives or our patients with diabetes, and we also worry about stroke. And it's incredible to think that a generic drug like Ramipril that costs £1.50 or probably about 100 rupees per month in Pakistan reduces stroke risk by 33%. Incredible to think that, irrespective of your blood pressure. Also, I think even better is if you want to reduce end-stage kidney disease over 4 years, this is a horrible outcome, extremely expensive with hemodialysis or kidney transplant, by using losartan, once again, about 100 rupees a month, reduce end-stage renal failure by 28%. So very good evidence that these drugs actually do work. So moving towards the end, I want to make it very clear to you that these drugs, that strategy does work. But there's no point in me talking to healthcare professionals about this strategy. How are we going to get it out to our patients is the main challenge, and in some ways the beauty of this strategy. First of all, everything that you want to do for diabetes can be summarized in a care plan for our patients, which is just a single piece of paper. So if you tell the patient what their cholesterol is, what their blood pressure is, then they're far more likely to move towards that target in terms of weight and exercise. So I give every single one of my patients a care plan. They often leave it outside the diabetes center with their packet of cigarettes and with a Coke tin, but I do make a point of giving it to them. 2 minutes, okay. Then we have a single piece of paper, so all our local GPs will get this single piece of paper, which I can give you today, which has referral pathways on the back, but a summary of this one-page guideline here, and that's updated every 6 months. We also have posters as part of the strategy to prevent diabetes, because clearly that's what our focus should be. So every time we have a new case of diabetes, we give them this leaflet on how to prevent diabetes. Because if I have diabetes, then the chances is that my wife is growing up in the same environment and at very high risk of diabetes. So we give that focus to say, let's prevent diabetes in your family. We are one of the first clinics in England, even in Nuneaton, to have a special clinic for Ramadan. And the reason why that's important is that during Ramadan, the tablets need to be changed. You cannot give somebody who's going to start a fast in the morning a furosemide, a diuretic. So we change it around. We change the dose of insulin around as well, and we've developed a very good care plan, so all our patients will have their treatment altered when we go to the Muslim center and advise them. And all our communication to the GP is in the same way. And really, I have finished early. This is my last slide. And the point I'm really trying to make is that when you see a patient, we should concentrate on aspects of advice, clearly, smoking, the physical activity, the diet, and the weight. We should aim that their blood pressure is 140/80. If it's slightly high, you cannot ignore it. You either treat it or say to the patient, get your own machine, check it at home. And we must also address the cholesterol, diabetes, eyes, feet, and guardian drugs. Thank you very much.
Thank you, Vinod, for such a lovely talk, and I'm expecting to just I can allow 1 or 2 questions. If any, yeah, Chairman.
Mr. Patel, excellent presentation. You mentioned about the diabetes and the aspects. However, you haven't mentioned about metabolic syndrome surgery.
Yeah.
Because that has certain benefits, and I think there is a mismatch and still probably slight reluctance to share that information with the patients as well.
Yep.
As statistics show that 50% of these patients after bypass operation, without having to lose their weight, will improve in their hyperglycemia.
Yep.
And either their medication dosage will come down or they will not require any medication after that. And another 30% will benefit after losing their weight.
No, I think you're absolutely right. I personally think that the commonest condition on planet Earth that requires attention is metabolic syndrome. After our patients people are fed and they have clean water and basic immunization, the commonest condition that we need to treat is metabolic syndrome. And the big problem is just that weight. You don't need to even have high glucose levels or blood pressure. You're absolutely right.
And its one benefit is that it reverses the HbA1c as well, which may not happen even with very well controlled diabetes.
No, you're absolutely right, and we need to see more of that in the future.
What about this oral insulin?
Yeah. Yeah, sure. The oral insulin, the bioavailability of oral insulin is very, very low. So instead of you having 10 units of insulin, we're probably going to have to give you 90. All right? There are some compounds that are 4 times the dose. And it's too variable. So I'd much rather have one injection with a 3mm needle and be happy, really. That's what I would do if I had diabetes. Because the oral insulin is so poorly absorbed, and it depends on whether the weather is hot or cold, or whether you have something acidic with it, or so I think it's going to be too variable.
Thank you very much.
Thank you. And if you want a handout, I'll just leave them here, okay?